Hi all, welcome back. We're going to talk about muscle tissue today. So the next few lectures are going to be about how muscles work, what controls muscle contraction and relaxation, kind of the makeup of the different muscles. Remember, there are three types of muscle tissue. We talked about them before. There's skeletal muscle with the striations, and we'll talk about what those striations are, and we'll talk about smooth muscles, which lack the striations, and then we'll talk about cardiac muscle, which has striations and intercalated discs. So let's jump into it, but first, let's jump into kind of a case or a scenario that is possibly related to the last topic and this topic and some others. Okay. So let's look at something that might occur. So let's say we're dealing with a individual who's at a Seattle nursing home, an elderly woman, Evelyn Hart. She was walking and she slipped, fell, and now she has a very sharp pain in her left hip and is unable to bear weight. So let's start looking at some vital signs and just start getting an idea of what these vital signs might tell us about what's going on, and that can connect us back to the physiology and the anatomy of the individual. So if we look at blood pressure, and we might say that this individual's blood pressure is 74/42, and if normal is 120/80, then that may not be normal for an 81-year-old woman, but we'll just say it's normal. Okay. It could be a little higher, it could be a little lower. It just depends on the individual and that individual's activity and kind of the size of the individual and whatnot. But at any rate, this is low. And so this should be an indicator right away. If blood pressure is low, it typically means if you think of a hose and you got the water pressure on in that hose, and at the tip of that hose is just dripping out, well, then you know that you must have a blockage, or better yet, in this case, it probably means that you have some leakage, which probably means that you have some internal bleeding going on. Okay? Let's look at another vital sign. If we look at the heart rate of the individual, and we might say the heart rate is 132 beats per minute. If normal was around 80, then we got to look back and we say, all right, low blood pressure, but high heart rate. So is that heart rate high because they're trying to, homeostasis is taking place and they're trying to account for the low blood pressure? Probably. It's tachycardia compensating for that low perfusion. Okay. Let's look at the respiratory rate. 30 breaths per minute. Normal is kind of around 15. Okay, so about double the breaths per minute. This individual is breathing pretty fast. Is that because the individual is not getting enough oxygen in their blood here? It's possible. It's possible. But another explanation could be that this individual is really stressed out and that the individual might be in pain and might have some acidosis going on. The individual could be hyperventilating because the individual might be going into shock. Okay. Let's look at another one. Temperature. The individual's temperature is 96 degrees and normal is 98.6. Okay, so this individual's cold. What could be going on? There's a few things that could be going on, but a good explanation for this is vasoconstriction. If there's less blood being pumped to the peripheral part of the body where you're going to take the temperature, normally with something like a little laser on the forehead, or a little paddle on the forehead, that's still that peripheral part of the body, and it could be vasoconstriction. You're constricting blood to that region. You're holding the blood internally close to the organs, and that could be causing the temperature difference there. Let's look at oxygen saturation. Again, low, 86% of room air. So normal is somewhere around 95. You know, this give and take depending on the individual, depending on the elevation, depending on where it occurs, but still nonetheless lower than you would expect. Okay, this is hypoxia, and could be due to poor perfusion or low perfusion. In other words, you have internal bleeding going on, heart rate's up, your breaths per minute, you would think, wow, you might be getting a lot more oxygen in, but if the blood's not moving, if you aren't pushing blood to the outer regions, then a lot of saturation cannot occur, especially because a lot of the oxygen monitors are off the tips of your fingers. Okay, and that's where it's picking up how much oxygen you have. And so if you have something like vasoconstriction and you're limiting how much blood's going to the fingertips, then you could have lower oxygen levels at the fingertips. The skin, so this patient's pale, cool, clammy skin. We would expect something normal, warm, dry. Depends on the individual's ethnicity and the color of their skin, maybe pink. Okay, be careful with this. If you know, often the perspective of a lot of EMT medical things are from the perspective of white people, and so pink might be a normal color. Pink meaning it's flush with color, meaning that the blood is in that region. So instead of looking at the hands, maybe you should look at the lips. The palms of the hands can tell you the difference there. But again, skin color, I would try to stay away from color of things, just because it's a little more difficult to talk about when we talk about color. But the coolness and the clamminess, or pale to the normal situation, could result in not enough blood flow in that region. And so if this is the case, these are kind of classic signs. This is what you should look for if the individual's going into shock. You couple that with a high heart rate and a high respiratory rate, the individual could be going into sympathetic shock. And then if you have mental status, if they're lethargic, delayed response, if they're confused when you ask them questions about time and place, or what was their last meal, this kind of stuff, you could have reduced cerebral perfusion, meaning that the individual is definitely kind of in a shock status, but also not getting enough blood to the regions of their body that need it. Okay. And overall, something like this, these kind of vitals might be associated, especially with an 81-year-old individual. It could definitely be a pathological fracture. We talked about these before. Remember, pathological is disease related. Okay, so she fell, but because of maybe osteoporosis or at least decreased bone thickness, the fracture might have happened easier. And then couple that with bleeding in the region, so capillary beds being burst and things like that. You could have definitely have some soft tissue damage, and then skeletal muscle could be damaged in the region. And that's really what we're going to be talking about in the next few lectures, is that skeletal muscle connection back to kind of bone and whatnot. If we go through some quick questions, just so we're on the same page. A long time ago we talked about what kind of homeostatic process would create an elevated heart rate, and that's the baroreceptor on the sympathetic activation, so B. And then we've talked about this a couple lectures ago. During bone repair, blank removes the damaged tissue while blank lays down the new tissue, and that's osteoclasts and osteoblasts. Okay. And then for those individuals that are in the Pacific Northwest or the Northeast or Alaska or parts of Canada, most of Canada, anywhere that you're far away from the equator, South America, where you have true seasons, and some of your seasons might be a long period of time without a lot of sunlight, we have issues with vitamin D synthesis in those regions. So you often have osseosis diseases that are associated with that. Less bone material being laid down and more bone material being decayed. And you couple that with an aged individual, and cardiovascular response is often lower because of things like the Hayflick limit, which we've talked about before, where your cells only can divide a certain number of times, and the older you get, the more of your cells that have already kind of reached that senescence phase where they're not dead, but they don't have the ability to replicate. So if you have damage, that damage is typically not restored to the original cell type. Instead, it might just be covered up by connective tissue or scar tissue, but the restorative factor is not there. And that can increase the risk of shock in an individual, not being able to respond and rebound from the injury. All right, let's jump into the muscle real quick. So muscles in general, remember, there are 3 types of muscles. Skeletal muscle, which typically attach to bones, and these are voluntary. So you can consciously control skeletal muscle. Okay, cardiac muscle, the muscle of the heart. Okay, the wall of the heart is made of cardiac muscle cells. Okay, it's involuntary. You don't have the ability to consciously control the heart. Okay, and of course we know that it's responsible for pumping blood, oxygenated and deoxygenated blood out of the heart and into the heart, technically. Smooth muscle. Okay, this is normally associated with internal organs and like the digestive tract and parts of other organs that we will talk about. Involuntary. Okay, so no conscious movement. You don't have control over how your intestines push food and create bolus and your stomach churning and that stuff. You don't have conscious control over that. That's all smooth muscle. And we'll cover all 3 of these in later lectures. All right, let's look at the structure of skeletal muscle. Some of these terms are going to be complex, but we'll break them down. And it's important because a lot of disorders and diseases are associated with certain features of the muscle and how it might fire. Okay, so first of all, skeletal muscles, there's lots of them. Okay? Over 600 skeletal muscles in the human body. They attach typically to bone, but they can also attach to skin in different parts, especially in the face. This controls facial movement and emotion and things that you can pick up in one's face. And they're under conscious control, voluntary control. Okay. Couple things that they're composed of. Of course, they're composed of skeletal muscle tissue. We'll dive into this and look at, well, what does that mean? Okay, the nervous tissue, blood, and connective tissue. Okay, again, we'll cover this, but nerves are needed to entice the movement of muscles. So you have to have a nerve connection in order to move your muscle. The blood is going to provide the oxygen and nutrients and energy in order for that muscle to move. And the connective tissue, it depends on the type, but if it's adipose, of course, that's going to provide energy and it's going to provide cushioning. But if it's other connective tissue, it might just provide something to hold it in place, or a covering that doesn't allow for it to be damaged, like a fascia or something like that. All right, so let's talk about those coverings, that connective tissue covering over muscle. Okay, the fascia or fascia is a thin covering that covers over the connective over the muscle. Okay, and it provides it support, but also it just holds it in place. Okay, and it keeps it from being bumped, bruised, torn, abrased, that kind of thing, along with other connective tissue around. Okay, a tendon is going to be a cord-like mass that comes off of the muscle and connects it to bone. And an aponeurosis is going to be a sheet-like connective tissue. And sometimes you'll see these sheets that cover, especially on places like the scapula, where the sheet will cover the muscle and kind of protect it, or cover it and connect it to another muscle. And then within or closely surrounding the muscle, you have other types of connective tissue. So it's basically breaking down the fascia a little bit more with the epimysium. Okay, this is going to surround the entire muscle. I'll show you a picture of this. Okay, it lies just beneath the fascia. Okay, the perimysium, that's going to surround the bundles of skeletal muscle fibers. And the endomysium is going to surround the muscle fibers itself within a fascicle. Okay, and we'll look at this here shortly. Okay, so if we kind of look at, this is a cross section of on a slide, and you can see the nucleated regions, so the nucleus showing up there in purple, and then you see these muscle fibers. The whole kind of bundle is a muscle fiber. That bundle will often have endomyosin in between those bundles, kind of surrounding them. Okay, and then a perimysin would cover this entire patch. Okay, and then an epimysium would cover all those patches, like this patch and the one that's over here and the one over here. Okay, all those patches together. Okay, and then that would be covered in a muscular fascia, and then it could be associated with a tendon that's attached to a bone, or it could be associated with other things. Okay, and we'll come back and we'll look at the other pieces that fall into this picture here shortly. Now, the reason why I bring that up is last time we were talking about, well, what happens if you get a fracture and you fracture a bone, and then you get a cast put on it, and you get a compartmentalization, or when the region is constricted by the cast, or by really anything else. Like you can have this by, if you put like a rubber band on the region and you constrict something really, really tight. Okay, that fascia will start to build fluid up underneath it, because the compartment is really just the group of muscles, the blood vessels, the nerves, and it's all enclosed by a fascia. Okay, and you can get compartment syndrome, okay, where you have fluid that accumulates within that fascia, within that compartment. Okay, and what that can do is, over time, if you get enough fluid, it can steal the oxygen out of the region around the muscle. Okay, so it can be like hold the oxygen in this fluid, which will cause, and nutrients, which will cause the cells to start to die. Okay, it can also push down and cause nerve pain on the nerve endings. Okay, so you can increase a huge amount of pressure. It's like a balloon that you're just filling too full with water but you have something fragile inside, and it's just pressing down on that material, and it increases the pressure quite a bit. One way to rid this pressure is sometimes a doctor will need to cut that fascia, and so it'll need to just slice it a little bit, release the pressure, allow that fluid to leave. Okay, and then that can relieve the pain, the pressure on the nerves, and hopefully allow the region to get the oxygen and nutrients it needs. That fascia or fascia is, again, it's not just one kind of wrapping. Like, I mean, some people think of it like a saran wrap over, muscle fibers, and it's a good way to think about it. But just realize that there's multiple layers. You can have deep fascia or fascia, subcutaneous that's going to be connected to the skin or right underneath the skin. And that fluid can build up between those facial levels or fascia membranes, and that's what can really cause some of these compartment syndromes and stuff like that. So it can be a little more complex than just one fascia or fascia and the fluid that is associated with it.